and really happy and that the senior leadership of OCHN have been able to join us today to present on their experience. And we're joined by Anya Eliason, if I, correct me if I made a mistake in mispronouncing your name, who's had a very long career at OCHN, and she's currently serving both as their interim CEO and the chief financial officer. She has a master's in business administration, and she's played a senior management role at OCHN for a long time as its CFO. And along with Anya is Nicole Lawson, who is the Deputy Executive Director and Chief Operations Officer. She's been responsible for the overall service delivery, planning, and management of access, clinical practice, justice services, quality management, service network programs, and contracts. She's a behavioral health provider by training. She has a master's degree in counseling psychology from Siena Heights University and a doctorate in philosophy in business administration from North Central University. So we're really pleased that that Anya and Nicole can share what is a really interesting experience trying to move to outcomes-based payment at OCHN. So Anya and Nicole, please go ahead.
Okay, thank you, Jim. So this is Nicole Lawson, and I'm going to kick us off, and Anya's going to take over here in just a couple of slides. So if we can move to the next slide, I just wanted to let everyone know a little bit about who we are and who we serve, as well as how we're structured, because I think it helps to frame the approach that we took to value-based models. So we serve about 27,000 people a year. We serve people with intellectual and developmental disabilities, mental illness, serious emotional disturbance, and substance use disorders. OCHN is considered an independent authority and a quasi-governmental entity. We're contracted with the state of Michigan to provide managed care oversight for people who require carve-out or intensive behavioral health care services. We have an annual budget of just over $300 million and manage a provider network of over 150 providers and about 300 service sites. So if we can move to the next slide. We're paid on a capitated rate, and prior to the development of our value-based payment models, we used not to exceed contracts that were cost settled each year. And after many years of operating that way, what we found was that there were significant rate variances between providers and some inconsistency in service delivery throughout our network without really any difference in the outcomes for the people that we served. And that was the primary driving factor behind the development of our value-based contracts. And as we move into how we developed these models, I just wanted to clarify that when we refer to value-based payment arrangements, we call them service models. We worked really hard to make sure that our models drive service delivery and really focused on the people receiving supports. And so we intentionally moved away from words like purchasing or funding when referring to our models. So just if you hear us call them service models, that's why. And we're definitely reflecting or referring to our value-based payment arrangements. So the goals you see on the slide were really what we wanted to achieve when we set all of this out. We wanted better service delivery, better outcomes. We wanted to be able to track our outcomes, eliminate that rate variance, and we wanted to increase efficiencies across the network. So after we developed our goal, if we can move into the next slide, we certainly had the moment of what if we just don't change and something magical happens when we get to achieve all of these things we know we need to do in the future. It is very overwhelming to start with, but we did start. And so if you can move to the next slide. When we began our journey, I think we had three primary advantages. First and foremost was our commitment to seeing this through. We believed very deeply in the direction we were heading and that it was the right thing to do for the people that we served. Second was our teamwork approach. We have an organizational culture that really promotes strong cross-team knowledge and expertise. So for example, I have a clinical background, but certainly can speak to our financing and have a really solid understanding of our financing. And when you hear Anya speak in just a little while as our CFO, she can talk clinical programming with the best of anybody across the nation. And so that certainly led to really good cross-teaming, different perspectives that I think helped us to develop those models. And last but certainly not least was our provider network. We have a really talented and committed provider network who are just as driven as we are to achieving better outcomes for people and really staying at the leading and cutting edge of service delivery. Certainly we had a couple of disadvantages going in that we knew as well. Compared to a lot of other managed care entities, we're relatively small and we didn't have a ton of funding to put behind our incentives. Secondly, this was a huge shift, so it required a heavy lift across the board for everybody impacted. It was a culture shift for our system as well. And next slide. So today we're going to focus on 3 of our service models, but we also wanted to highlight a couple of broader concepts that we think folks might find useful. And first is our approach to our payment methodology. So we don't believe in a one-size-fits-all. We wanted to look at each level of care and at times each specific service as a unique way to support people, and we wanted to pay our providers accordingly. And so across the 15+ models that we've developed at this point, we have some combination of all the different payment methodologies that you see on that screen. One of the methods that folks might not be familiar with might be the milestone payment. And we use that particularly when a provider reaches a goal or a milestone, such as someone being employed for a full quarter or a full year, or when a provider achieves a certain level of an incentive, such as providing X number more units of peer services over a defined area or time period. Next slide. So the other thing we wanted to touch on that's a broader scope are our outcome and incentive measures. And we intentionally created incentives that addressed both outcomes from service delivery, such as inpatient admissions or readmissions, but we also created some that addressed areas of the social determinants of health, like employment or healthcare, because we know how much those factors contribute to a person's overall health and wellness. And so to decide on what outcomes or what incentives we wanted to use, we brainstormed several. And then we went ahead and pulled 6 quarters worth of data to look at current performance and really define, is this something we think anecdotally that we need to improve upon, or does the data really tell us that this is an area that is we need to kind of focus and buckle down on? And so that data also then served as our baseline, and we determined the target that providers would need to achieve in order to receive a payment incentive based on those 6 quarters worth of data. We wanted this whole process to be very transparent. And so to that end, we work with our providers to develop the logic to pull the data, and then to develop the wording and the logic around both the payment and the incentives. Sometimes we think this is what we want to get to, but they can help us understand that by measuring something in a little different way or adding a certain data element that will get to where we want to go a little bit better. And we publish all of these details in our service models, and our providers also have access to dashboards that tell them in real time how they're performing. And you'll get to see some of the dashboards and the outcomes that we provide for our network a little bit later in the presentation. So here are just some examples related to performance incentives for service delivery. And these are intended to be stretch goals. And so we identify areas for improvement that would require more than average effort on behalf of a provider to attain. So certainly emergency department admissions, psychiatric inpatient admissions, and readmissions are areas of high level focus for us. Moving on, we also have the performance incentives related to social determinants of health. And so like we want to make sure that people have stable housing, that they're not living in hotels shelters or other impermanent types of situations. We also wanted to increase the number of people we serve who are competitively employed in integrated settings, and ensure healthcare coordination, which we define and measure as someone having seen a primary care provider in the past 12 months or having received a basic health screening from one of our behavioral health providers that consists of height, weight, BMI, blood pressure, and an HbA1c lab draw, again, within the past 12 months. And so looking at outcome measures, and you'll hear us talk about incentives and outcomes, and we do define them differently. And that's been something that for us has evolved since we started doing service models. And while an incentive is intended to be a stretch goal that requires more than average effort, outcome measures are areas of focus that we as the funder have identified as important, and that we consider to be part of regular service delivery, but we want to see improved metrics around. So we've added funding that providers can earn when they achieve this outcome that we identify. But if those outcomes aren't achieved, we do require a corrective action plan that we ultimately approve so that we can be assured that these areas are going to be addressed. And again, that's different from an incentive because incentives are just above and beyond and kind of a bonus payment. So with that, I'm going to turn it over to Anya, who's going to walk us through our employment service model.
Good afternoon, everyone. My name is Anya Eliason, as mentioned, and I will be walking you through a couple of our service models. The first service model we did, and we actually worked with a national consultant to do so, was our employment service model. So the overarching goal was to increase the number of working-aged adults into integrated employment with a minimum competitive wage competitive employment. So the definition we use, moving on to the next slide, for integrated employment is individuals working paid directly by the employers occurring in a typical community-based work setting, meaning elbow to elbow with the general population, and competitive wage meaning at least minimum wage. Next slide, please. So the main points of this particular service model was to establish rates for community-based service provision that were different from facility-based service provision, addressing staff-to-person ratios in order to de-incentivize large group settings. And then ultimately, the goal was to pay for the number of hours worked regardless of the actual face-to-face job coaching time. In Michigan specifically, historically, we have only paid on the face-to-face time that an individual receives job coaching. And what we found is not only does that not necessarily incentivize competitive employment specifically, but it doesn't necessarily incentivize fading. So we found that we had a lot of people that had 100% fading or 100% job coaching at their job for several years on end. And so when we altered to this funding methodology, we definitely saw that change as time went on to reduce the number of actual staff hours necessary to be face-to-face with the individual. Next slide, please. So in developing this particular service model, and in any of our service models for that matter, we really start basically at ground zero when it comes to rate development. We look at all of the components that are going into what we're paying for, and then adjust those accordingly to make sure that we are reflecting the appropriate amount of time the person has to spend with that individual and without that individual for travel time and those types of things. So walking through this slide fairly quickly, but just to go through it, the job coaching, let's say the job coaching hourly rate is about $11.33, and employee-related expenses are added on to that. You can see those listed there, being benefits, and how those are added to the hourly rate, getting us to $14.34. We have to add administration, we have to add those types of things, overhead, and then adjust for the actual amount of hours there are in the day. So if you have an individual that you're paying for 8 hours in a day, the reality is they can't actually bill for that many hours. So we have to adjust down for the amount of time the person can actually bill. So if you look at the bottom section there of that slide, what you see is us taking a roughly 7.5-hour day and taking away the amount of time that they're not actually able to bill. So we have to gross this up to an annual amount and then subtract that to get what is a typical hourly compensation after you subtract the part of the day and part of the year that the individual is not able to bill. What we call that is a productivity adjustment. And what that does is results in grossing up the rate in order to cover that non-billable time. Next slide, please. So the way this particular service model worked is there was an acuity tool done on each individual that was competitively employed and determined to be of high, medium, or low acuity. The tool in particular was about an 8 or 9 question tool that helped understand the amount of support someone would need. And then it also factors in the amount of time an individual was on their job. So you can see 0 to 11 months is phase 1, phase 2 is 12 to 24, and phase 3 is 25 and beyond. So the key here is that the job coach is paid for as long as that individual is employed. The goal being for that individual being employed, and then you're not, the job coach is not essentially working themselves out of payment when they're fading and increasing independence for the individual served. So for a person that is considered high acuity and in phase 1, the gross up rate for that individual's time is then multiplied for the expectation that they would spend roughly 85% of the time that individual works face-to-face with them on their job. And what you can see is that fades over time and with acuity. So as someone progresses through being on their job, 12 to 24 months, the expectation of face-to-face support drops down to 70%. And then finally, if you were high acuity in phase 3 and on your job for 25 plus months, it would drop to 60%. So again, the job coach gets paid for as long as that individual is employed. And they then have the flexibility to support that person with their job when they need it and as much as they need it. These percentages are not a minimum expectation. They're only used to calculate the rate. And it is based on an original data set identifying for these individuals what the average amount of time face-to-face would be needed in these job coaching situations. So go ahead and move to the next slide. So on top of funding really for the outcome we were looking for, which is having someone employed, in addition to that, we added a couple other things to this particular service model, which was trying to make sure that we were focusing on getting staff trained so they were able to help a person maintain their benefits even while they were working. Some of the feedback we got from some individuals is that they didn't want to work because they didn't want to lose their benefits. So we wanted to make sure that our network was trained in how to make sure to best utilize the programs that are here in Michigan to allow for people to work and maintain their benefits. So we provided an incentive as staff were able to get trained on that you can see 33% trained, they got an incentive. We also believe very much in competitive integrated employment, meaning we wanted people to be paid at minimum wage or above. So a 14C certificate, for those that aren't familiar with it, allows a employer to pay less than minimum wage. So we did add an incentive that pays an employer or an employment provider for not renewing their 14C certificate. In addition to that, we provided an incentive for providers when they increase the amount of community-based skill building by at least 20%. So when we started this, we had a lot of providers that were primarily facility-based, and we really wanted to encourage them to get people out in the community and do skill building in the community in a bank or in a grocery store or in whatever setting that would be a typical setting for an individual being part of their natural community. And then finally, we provided an incentive to increase the number of people served who are employed competitively within the community. And that was a $5,000 incentive. Next slide. So what we found after 12 months, we saw an increase of 135% of people who were in those competitive integrated employment settings, really, which was phenomenal. We expected to see this go up. I think we were really happy to see it at 135% increase. We still have lots of room to improve, but feel like we're getting where we want to go with this type of funding methodology. We found that 59% of those people moved on to phase 2. So what that means is they were employed for at least 12 months or more. And so that demonstrates good fit, good support, and those types of things. In addition to that, we also saw 17% of them transition to a lower acuity level, which was a bit of a surprise, but as people are integrated with their job and successful in their job, they're learning supports and able to have fewer supports that are paid supports as opposed to natural supports, and therefore lowering their acuity in the acuity tier. Next slide, please. So now we're going to talk a little bit about our ACT service model, or Assertive Community Treatment. So this was really the second service model that we developed and implemented. And this was the first one that we didn't have the national expert we used. This one we did have a contractor in the beginning, and then kind of found that after we did this, we felt like we were pretty comfortable doing this on our own. But the ACT service model was chosen to be the next one because it has such a prescriptive model of service with very specific staff and very specific caseload requirements. So in this particular model, we started in October 1st of 2016, and it's essentially a per member per month payment, and the model expects fidelity to the evidence-based practice and measures outcome and consistency and cost. Next slide, please. So in this particular service model, for ACT, there is only one code, and so it's a bundled code based on that team composition. So any ancillary services that are outside of that bundled code were funded separately based on a group of codes and how much we expected those group of codes to cost on a per member per month type basis. In addition to that, for any therapies provided, what we've done is allowed for any evidence-based practice therapy gets an enhanced rate. For us, it was 12.8%, and that was really just based on historical data that showed that typically when we paid for services, if it was an evidence-based practice, it was a 12.8% premium that was added to that to be able to fund that and make sure you held fidelity to the model. Next slide, please. So this particular service model, you can see, it's a similar setup to how we developed the rate for the employment model, in that we took the costs of each of the staff. We also took the benefits, overhead, and those types of things. This structure is fairly similar across all of the service models, where we take from the ground up and really build the rate based on who it is we're paying for and how we want to pay it. So in this particular model, we do have caseload size requirements. So this staffing structure is specifically like this, and then it only allows for a specific caseload size. So that helped us kind of develop that per member per month payment. And what you can see there down towards the bottom is the variance from the historical per member per month that we really were paying, which was just by default the expense that we were paying by provider. So what we found is we were able to create consistency in not only the model, but also in the funding. And one of the things that we've added to all of our service models, because we are a nonprofit governmental entity, is a 2% profit cap. So while I, as the CFO, am very interested in people having strong businesses. I do also recognize that we are a tax-funded organization primarily, and it's important that excess savings come back to be reinvested in the system. So that's been something that we have unilaterally added to every service model, and definitely we feel like make sure that there is no unintentional gaming or a way to take what we have done and try to cut costs to a level to solely focus on profits. Just going back to that, just for one quick second, is that any incentives are outside of the profit cap. This is really related to just the per member per month funding. Okay, move on. Thank you. So what you can see here is from fiscal year 16 through fiscal year 19, we were able to see reduction in the actual cost per member per month. So we did end up with a cost savings from this particular service model. Go ahead and move on. And that's where I believe we are going to pause to take a couple of questions if there are any, and or then move on to Nicole looking at the outcomes from some of the service models.
Just a reminder that if you have a question, feel free to chat it into the chat box.
Okay, so if there aren't questions, just for time's sake, we'll go ahead and move on. So now that we have several years of service model experience under our belt, so to speak, we can look at some longitudinal data and trending for our incentive and our outcome measures. And so the graph you see on the screen is an example of our ACT data related to healthcare coordination. So again, we define that as having a primary care visit or a basic health screen within the last 12 months. The lighter lines that you see are individual provider performance by quarter, and then the darker lines are the trend lines for each provider over 2 full years. And that solid green line at the 95% mark is our target for providers to achieve that incentive. And so, well, you can see from this, while provider performance might be up and down by quarter, we have clearly defined upward trajectory in our trend lines. So we know from a systems perspective that we're certainly headed in the right direction. And if we take a look at the next slide, you'll see the same type of graph, and this represents our outcome areas for crisis contacts. And so for the ACT model, this is defined as the number of contacts at our crisis center. And we want this to be a downward trend for our providers, since our expectation is that the ACT team is responding when people are in crisis versus going to our countywide local crisis center. And so again, you can see that performance per quarter varies significantly amongst our providers, and we have 2 providers who have somewhat of an upward trend, and then 1 who has a downward trend. And looking at the next graph, this shows our inpatient readmissions. And you can see, again, just the variance between providers. We have 1 trending down, 1's kind of level, and 1 is trending upward, despite all of those ranges in quarterly performance. On this one, we do include our second graph for scale, as all 3 of our providers have maintained an average readmission rate of under 3% for 3 consecutive years. And so we wanted to acknowledge that as well. So in addition to looking at the data this way, we also just look at change statistics over time, and that's shown in the next slide. And this is just another way for us to look at trends. It gives us a snapshot of incentives and outcomes and whether or not they're trending up or down. And so this slide is an example of 3 areas where we want to see an upward trend over time, and you can see that we are indeed hitting that mark. The next slide shows us change statistics in areas where we want to see a downward trend, and you can see we have several upward trends in these areas. So all of this data is really important because it helps us to understand not only current service delivery, but the current environment that our provider network is delivering services in. And then that really informs the conversation that we have when we review these models with our provider network every year. And it allows us to determine if we need to adjust any of our incentives or any of our outcomes expectations. And so we use the knowledge that we gained across the development of the employment and the ACT model to develop our next model, which was slightly more complicated, and that's our outpatient or targeted case management model. And Anya is going to go ahead and walk us through how we developed that one.
We did have just one question that was chatted in about the ACT model, if you wanted to answer that right now. Otherwise, you can save it for the end.
I'm happy to answer it right now. I can't actually see the question, so if you don't mind.
Okay. Yeah. So the question was the ACT PM across the entire member population?
Yes, for anyone receiving ACT services, it was implemented across the board. I think at the time when we implemented, I want to say that was roughly 200 to 300 people. Nicole might be able to jump in if I'm incorrect on that number.
You are correct on that number.
Okay, so moving on to our targeted case management model. We started that in October of 2017. So this one was a little more complicated just in the variety of services that are included in this particular model. So targeted case management in and of itself ended up being a PM type situation. But then we had to add in things like therapies and peer services and other types of services that are typically received in addition to targeted case management. And so moving on to the next slide, we can talk through kind of the rate development again. And so in targeted case management, you can see the primary code being T1017 for us. But what we also added into that was assessment codes. And that's what those two H codes you see there. And so what we did was basically bundle all of those codes and say that if anyone reports any of those codes in a particular month while in targeted case management, that would trigger the PM payment. And you can see, as we walked through before, it's the same rate development structure in that we take the salary, benefits, and overhead, and we adjust it for caseload sizes. So I would say caseload size was probably the biggest discussion we had, and kind of just working with our providers, just in at what we thought was realistic versus what they thought was realistic, understanding that it's that productivity factor. So while we would expect a caseload size typically far higher than say 33, the reality is much of their time is spent doing outreach and those types of things that may or may not result in an actual encounter that would trigger payment. So what that ends up resulting in is us essentially just reducing the expected caseload so that the number of people that they do see does essentially cover cost when you account for all of the people that they weren't actually able to physically see, considering outreach and those types of things. So moving on, so you can see the other services included in this particular model. This is a chart that really speaks to all of the other things. So what we did with peer services is use basically an average historical cost, because what we found with peer services is while peers in and of themselves, the rate wasn't particularly high, the level of supervision needed and those types of things. So rather than try to estimate what that would be, we use the average historical cost, understanding that we have roughly 12,000 people in our adults with mental illness population, and the majority of them would fall into this case management category. So it's a fairly large number of people that we're using as the population to get the average. I apologize, that is my... moving on from that, oh, sorry, I wasn't through with that slide. I was just busy dealing with the dog. Community integration supports. Sorry about that. Community integration supports. So again, you take average historical cost, and community living supports, we use the historical average for the per diem. Housing assistance, that one was basically an at-cost item where we used the actual cost, because housing assistance for us is really something like a down payment on an apartment or a utility bill or something like that. Med management services, we grouped all of those together and used the historical average. And you could see med management with health services is slightly different because it's a different group of people typically that provide those. And as we talked about before, the therapy codes were based on historical averages, but then also have the evidence-based practice add-on should someone be using an evidence-based practice. You can move on. So the pre-model average per member per month was roughly $521. And the first year we implemented this, there was some, we allowed some basically risk coverage is what we titled it. But basically, if a provider had struggles getting to live within these rates for the first fiscal year, we would work with them to help them cover those costs if they were able to implement a corrective action plan that we felt got them to the appropriate amount by the next fiscal year. So the first fiscal year you can see only slightly adjusted down, but then going on this fiscal year 19, you can see it actually ended up slightly more. And that just depends on, again, the ultimate caseload size and those types of things after we backed into the number of individuals served. So what you can see here is the drastic drop from the fiscal year 18 cost per readmission goes from 22,000 down to 7,000. So we did see a definite reduction in costs related to readmissions. So this is how we typically monitor our service models and service model outcomes. So we have dashboards, and you can see these are based on specific providers and specific time periods. And you can see the comparative, the number of people that were eligible to receive a payment and the number of people that did. And so what this does is helps us and our providers kind of know the expected amount they should be receiving for a particular service model. And also they have the ability as providers to drill down into this data so that if there is a higher number of people who are eligible to receive the payment, who they did not get paid for, they can drill into who that is and determine what is the issue with it, the reporting issue, were they not seen, or what's really causing them not to actually be paid for that particular person. I think that's it for this particular slide. And then I believe we are going to pause and Nicole is going to look at outcomes.
Yep. Thanks, Anya. So just like with our ACT model, we use the same data and trending analysis just to see how we're doing across all our service models. And so the graph you see on the screen right now shows the steady upward trend we have for our healthcare coordination incentive. But the difference here is the solid green lines that you see reflect the change in our expectation for providers to receive the incentive payment. So as they continue to improve, we continue to raise the bar until we hit the 95% expectation that we're held to through our contract with the state of Michigan. And looking at the next slide, it shows provider performance for adherence to our crisis planning protocol. And so this is an outcome measure. And when someone presents at our crisis center, our protocol or care pathway says that their plan needs to be reviewed and updated within 30 days. And as you can see, this has been an area of focus for a few years now. And it is an example of an area that started out as an incentive, but it's now an outcome area. So this fiscal year, if providers didn't hit their goals in this area, they will have to develop a corrective action plan that we will then approve to make sure that we're hitting the changes that we wanted to see in this particular area. And the next slide, unfortunately, we did a boo-boo when we added this slide in because it's a repeat of our ACT inpatient readmissions. So we'll go ahead and skip to the change statistics for our targeted case management model. And again, this is just another example of how we take a look at the data across all models. And this is areas that we would want to see trending upwards. So when we see change statistics like this, that makes us happy because it tells us that we're on the right track. Looking at the next slide, these are areas that we would want to see trending downward, but we have upward trends. So as we go to review our models this year, these are the things that we're going to have to discuss about. Are our expectations just off base? Are they not reflective of the environment that services are being provided in? Or are there other things that we can do to further work with our network so that we start seeing the downward trend that we would want to see across these areas? So talking about lessons learned, and I think the hardest part of any project like this is just getting started. It's really, really easy to get overwhelmed and have some analysis paralysis when you have all of this data that you're looking at. Ultimately, what we found to work best is to have an initial discussion with our providers, just letting them know that we intend to move into a value-based model or payment arrangement, and work closely with them. So starting to brainstorm systemic changes that everybody wants to see, as well as what potential incentives could be. We take all of that information back and we build a draft model. And we develop an outline for service delivery. We pull data for the incentives. We gather all of the information that Anya went over for rate setting. And we send that draft out to the network providers. And then we meet with them as a whole group. And we review those drafts. We get their input, their ideas for how to operationalize some of this, and then we negotiate targets for outcomes or incentives, again, as a group. And it's an iterative process. So we take that first draft back, we make adjustments, we send a second, and we repeat that process sometimes over the period of several months until we have a model that we're all happy with and we feel like we can live within. So it's important to note, again, Anya had mentioned it, but I think it's worth noting again that in order just to get that buy-in and protect our provider network, we include that risk language for the first full year of implementation. It really inspires trust and just reinforces our commitment that this is going to be the way we fund to move forward. And so when it comes to building this type of a model, I can't stress the importance of partnership with your provider network enough. We learned really early on through doing it wrong, quite frankly, and making a mistake, bringing the providers in too late. We thought we had a finished product. They were just seeing it and felt completely left out of the process. And so we really learned that the earlier that providers are pulled in and included in the process, the better the product in the end. And certainly the discussion, consultation, and negotiation process all goes much more smoothly as well. When developing incentive language or logic, simple is better. I would highly, highly recommend that you find ways to use your existing data points, that you avoid things like developing new assessments, new reports. And I would also say that less is more, in that the less incentives or the less number of outcome measures that you're focused on, the more heavily you can focus on them. Too many incentives or outcome measures can be overwhelming across the board. And last but not least, the lesson learned is just don't be afraid to start. It's okay to fail forward. We have changed and evolved so much over the years in the implementation of these models. You can be flexible and you can make those changes as you need. Just don't be afraid to get started and to move in that direction. And so with that, we would like to say thank you and open it for questions. I think 1 minute early.
Thanks so much. We did have a few questions come in. Other folks, feel free to chat in or use the Q&A function. The first question was, what was your biggest surprise and challenge from doing this work?
I think for me, and Anya might have a different one, but it was that incentive measures are hard. I did not expect to put the amount of time and negotiation into developing logic and measurement for incentives that we did. And then creating dashboards to keep us all on the same page, months. We put months into that every single year. So again, learning by failing forward to some degree. That was why the recommendation was to use your existing data points. Don't try to do self-reports or other assessments. It can get really messy really quickly. Anya, I don't know if you had a different one.
I think I would just lean back towards the biggest surprise was probably just thinking we had it figured out with that first one, and the reaction and how far that kind of set us back by not bringing in providers early enough and really having those extended conversations to get the buy-in. The buy-in was far more important than I really ever expected it to be. And, you know, we learned by failing, and now we do it differently. And I think now our approach is really much more collaborative, and we end up with a far better product.
All right. So the next question was, what parts of this approach do you think could apply to any market, i.e. what parts are not Michigan market dependent?
I guess from my perspective, and again, Anya might have a different one, I don't know that anything's necessarily just dependent on the Michigan market. The approach we take to rate development and incentive development could pretty well be applied across the board. The only tweaks or changes folks might want to make is, you know, we chose to go with historical rates in some aspects because we wanted to preserve some elements of our system. Whereas other people might choose to follow the rate setting methodology in terms of, you know, staff salary and those kinds of things. Anya?
Yeah, I would agree with that. I don't think any of this is particular to the Michigan market or even behavioral health for that matter. It's really just about deciding what you're trying to buy and being creative in how you're trying to buy it and how you measure it.
Okay, so the next question is really two questions. So the first part is, what does data sharing look like for care coordination with partnering entities, i.e. primary care?
So in terms of primary care, when we talk about our provider network in this realm, it is the behavioral health care network. So things very specific to the Michigan market with sharing data with our primary care partners is we have a statewide data set, and the state gives us a platform where we can share claims adjudication that are specific to Medicaid. And then we do have some health information exchanges that are out in the network where you can subscribe and you can get things like lab data and other things.
Okay. So the next part of this question was, given varying levels of acuity or client needs for case management services, is there a particular time frame that clients are typically engaged in the PMPM services? And is there a graduation or relapse prevention planning built into the service model with client self-management goals?
So people are paid in the PMPM for however long they remain in our services. And the nice thing about having done the service groupings is that services can be added, enhanced, reduced, or stopped, just depending on the person's needs. And so they would remain in the PMPM and within the bounds of the service model until such a time as they would be able to graduate, so to speak, or be transitioned into community-based supports and services. So what's important to remember is we are a carve-out system. And so we are only intended to serve the people who have the most intensive needs. So at a time where they could go and be served in the community by non-carve-out resources was when they would graduate. But then we have other requirements and things in the state of Michigan whereby if someone's in our services and they are transitioned to community-based services and they need to re-engage us at any time within the next 365 days, they can do so without having another eligibility evaluation. If it's been longer than 365 days, then someone would just need an eligibility evaluation. And then in terms of the rest of the continuum of care, if someone was in our targeted case management or our outpatient model and they needed ACT services, they can just move into the ACT service realm. And, you know, if their needs decrease, then they can move back into outpatient services without any kind of penalty to the provider.
So just to add to that, for incentive measures and outcomes, we do wait till someone has been in a particular level of care or service model for 90 days before they are incorporated into the outcome or incentive measure.
Okay, our next question comes from Jim. Can you talk more about provider perceptions of your service models and what they saw as their greatest barriers?
So the perception at the very beginning wasn't all that great, and I think we own that. because that was where we talked about having made the mistake of pulling in our provider network too late. So we thought that we had kind of everything figured out, and they were just kind of coming in the back end, and that did not go over well. Overall, I would say the first time any network enters into this type of service model, it's scary, because it is asking them sometimes to completely change the way that they deliver services. And it's certainly any kind of change to your bottom line or the way you've been operating puts you on shaky ground. And that's why we entered into that risk language that Anya had mentioned for the first year. It just, I think, helps to calm some of those reserves and let providers know that we're really in this with them and that we're invested in them being successful. And then the more we work with our provider network, and we've developed that iterative process that I talked about, where they're involved from the day we start rate setting, and they understand how we're approaching that, and they are the ones that provide all of the information about how their rates are developed and how their incentive logic is developed, that it does become more of a partnership. So while they might be a little bit more on edge and nervous because it's something new, I do think that over the years we've been able to at least develop the reputation that they know we're invested in their success, and that we will be working with them to make sure that they're able to implement this successfully. Anya, do you want to add anything to that?
The only thing I would say we could add is that it's definitely a level of predictability now in how they're funded and how they're measured. They know at the when they walk into a year exactly how they're going to be funded based on what information and how we're going to measure things. And so that's a big difference from how we historically had funded them, because it was basically a pot of money they had to live within regardless of the number of people they saw. So this actually does take and put some of the risk back on us as the funder. And I think that it, again, has created a different partnership, and not just you're on your own, figure it out kind of partnership that, as Nicole mentioned, we really do work together to try to continually raise the bar. And I definitely think that they're interested in that as much as we are.
Okay, we have time for just a couple more questions. So the next one is, are you changing your service models or developing new ones in response to COVID-19?
So I will say that what our goal for COVID-19 was to stabilize our network and sustain our network. And so what we did was basically say effective March, for us it was March 16th, that we moved to a cost reimbursement methodology. And that was really because we wanted to be there to support our network, recognizing the complete chaos it was there at the beginning. And we wanted them not to worry about the number of encounters they were getting in and not worry about how they were going to make payroll. We wanted them to know we were there for their support, and we were going to make sure that they were able to cover costs. And so we've gotten a tremendous amount of positive feedback for how we handled that. There are some other places in the state that did not handle it that way and who are having a really hard time. And we feel like that was our role as the managed care entity, is to take on that risk during such times and to provide, the guidance we have while being flexible to help them serve people, because that is our goal, is that they were still able to serve people and keep moving forward during this. So we'll go back to the service models when we feel like the system is in a place where they're able to. Right now, our goal is to just make sure people get served. I don't know, Nicole, if you have anything to add to that.
Nope.
Great. Well, thank you both so much. I'm going to wrap up for today, but thank you very much for sharing all of this. As I mentioned earlier, this webinar was recorded, and the slides and recording will be posted on the Delta Center website. And if you have any questions, feel free to email us, and we will coordinate with Nicole and Anya to answer anything further you might have. And thank you very much. Have a good rest of your day, everyone.
Thank you.
Thank you.